hormone that regulates sodium reabsorption is ANP. ANP is called atrial natriuretic peptide. This is secreted by the atrial wall cells or the heart cells, and it is in response to a distension in the atrial wall. So when we have an excess distension of the atrial wall, that is indicative of increased blood pressure. So right off the bat, I want you to think about angiotensin. I want you to think about aldosterone and ANP as antagonistic hormones. Aldosterone is going to increase sodium reabsorption as a response to decreased blood pressure. ANP is going to decrease sodium reabsorption as a response to increased blood pressure. So the trigger for ANP release is increased stretch on the walls of our heart, which is signaling increased blood pressure. And the response that ANP is going to bring about is increase in GFR, which it does by dilating the afferent arterioles and constricting the efferent arterioles, meaning that we're going to now filter more fluid across the glomerulus, right, increasing our GFR. And that is a way for us to clear more fluid out of the body, right? Remember, if we lose more fluid, we're going to bring our blood pressure back down. And that is what we want when we release ANP, or atrial natriuretic peptide. So this decreases the amount of sodium that is reabsorbed, closing those sodium channels on the apical membrane. The overall effect is going to be decreasing our sodium reabsorption or increasing our sodium excretion. We're basically going to lose or waste sodium into the urine. That is going to help us to decrease our blood volume, decrease our blood pressure. Remember, I said that sodium is followed by water. So if I lose sodium into the urine by preventing or blocking sodium reabsorption, I'm also going to lose some of that fluid into the urine, and I'm going to bring my blood pressure back down. And that is going to decrease the amount of distension or the amount of pressure that is being put on the walls of the heart. Okay. So here we have another flow chart that's kind of depicting that, right? Increased plasma volume triggers an increase in the walls of the heart, the stretch on the walls of the atria. That triggers the release of ANP. And ANP is going to increase our GFR by dilating the afferent arterioles and constricting the efferent arterioles. So that's going to force more blood to go across the glomerulus, which will increase our GFR. Increasing our GFR will mean that more fluid is being moved through the kidneys, more sodium is being excreted. The ANP is also going to stimulate the principal cells of the distal tubule to block that sodium from being reabsorbed across the apical surface of those cells. So we're going to be absorbing less sodium and excreting more of that sodium into the urine. And then that is going to trigger increase in sodium excretion, which will then facilitate the drop in blood pressure, okay? And then we notice here that decreased renin secretion is going to be a product of that. So remember I said the ANP and aldosterone are antagonistic. So if I increase my ANP secretion, I'm going to decrease my aldosterone secretion because they're doing the exact opposite things. Aldosterone wants to suck more sodium back into the plasma. ANP wants to push more sodium out into the urine, right? So if we increase ANP, we've got to decrease aldosterone. Okay, and we'll skip over these checkpoint questions. We'll probably look at this as practice. So we'll skip over these and I'll come back to those next time we meet. And then the last objective here, we're going to talk about the role of aldosterone in potassium. This is pretty straightforward. We can speak about potassium balance in a very similar way that we did with sodium balance. Hyperkalemia is going to be high plasma potassium. Hypokalemia is going to be low plasma potassium. And we know that we want to keep this at a regulated level. We don't want high potassium. We don't want low potassium. Potassium is crucial to the function of our excitable cells as well. Again, we're talking about the action potential occurring in muscle cells, occurring in neurons. And we know that potassium is required for that function. So we want to keep potassium very much regulated, and we neither want it in high concentrations nor low concentrations. So potassium is handled through the kidneys. It is freely filtered across the glomerulus. It is reabsorbed across the proximal tubules, unregulated reabsorption that is, and then it is regulated in terms of its reabsorption and secretion across the distal tubules and the collecting duct. So one important difference that we notice here about potassium is that it is reabsorbed and it is also secreted, right? We saw that sodium was not secreted. Potassium is reabsorbed and secreted. Potassium secretion happens in the distal tubule and the collecting duct, and it is regulated under the influence of the hormone aldosterone.